and influencers, ask any question on the subject. Traditional media, ask any question on the subject. And I just want to reaffirm that this is not political. We came here to teach you medical facts, and our freedom depends on you being medically informed. So thank you, and turn it back to you, Simone.
Yes,
Or?
actually, yes.
There you go. Thank you.
All right, so I'm very excited for everybody today, but I'm going to introduce my colleague, Dr. Richard Ozzo, who's just going to give us a brief overview about the disease, the virus, just get us started, okay?
Well, I'm so excited to be here. I think I'm gonna have to hold this up. Can you hear me pretty well? So I'm excited to be here for several reasons. The biggest reason is something that Dr. Gold touched on earlier. This is the first time historically that I've ever been in practice that we've told patients with the disease to go home and isolate. It's never happened before. It's almost insanity, all right? So would I tell a cancer patient to go home with a tumor, wait till it gets a little bigger and impinges on the breathing, and then come back and treat? No, it would never happen, all right? That's what we're doing on this disease. Would I tell a patient with bronchitis, wait till you have pneumonia, come back home, come back to the doctor? And that's what we're doing here. That's the insanity of, and that's the reason we're here. We're letting patients perish unnecessarily. I want to say that again. We're letting patients perish unnecessarily. And that's the reason why we're here. We know we have good treatment. We have a prophylactic treatment that in very low dose that will, in studies shown 80% reduction in how much the ability is to get the disease. We have early treatment regimens that will work extremely well. And I'm going to touch a little bit on that later today, and we're going to talk about, as she said, the late treatment. But in general, that's the basis of why we're here. We do not let patients perish at home and isolate. That's insanity. All right, so with that being said, what is COVID-19? So this virus is a member of the coronavirus family, and this is the 7th member that we know of. And historically, those viruses have been basically like the cold virus. We've had some more severe flu-like incidences with SARS and MERS, but historically it's been a relatively mild virus. All right, so in general, we've studied these viruses for 60+ years. So there's a lot of data. And what Dr. Gold alluded to is that a lot of that data applies to this virus. And we've been able to use that. And now other people have actually come in and confirmed that some of these medications work. Things that we've worked on for years, especially given the bad outbreak in SARS in the early 2000s. So this is not a mystery virus. So we've got to take the blinders off, okay? This is not a mystery virus. It's a member of a family. And if you've ever studied anything, if you know the family, you know something about the individual in that family. So think about it that way. We know this family of viruses, and because we know the family of viruses, we know this individual virus to a large extent, how it behaves and what it's going to do. Yes, it's unique. They all are unique. And as we know, RNA viruses, they mutate quite a bit. So they don't have a protective coating. So even now, the same virus that was in China is not the virus that we have in Houston or in California. All right, remember that, because as we go forward, what have we been told? We've been told to stay at home, isolate, mask, wait for a vaccine. What's the likelihood of that vaccine actually being successful? Well, do we have an HIV vaccine? No. Do we have a great flu vaccine or a cold vaccine? Well, we have a reasonable flu vaccine, but it's like a dog chasing his tail. We're constantly chasing after the proper formula for this vaccine. So we're very hopeful that vaccines take hold and they become successful. I'll be excited about that. In this individual virus, there's a spike protein, which even though there's been 6 to 8 mutations around the world, that spike protein that they're going after for the vaccine seems to be pretty well preserved despite the mutations going on in the virus. So we're hopeful for the vaccine, but that's not a good strategy for people that are sick right now, and definitely not a good strategy early on in the disease where we know we had no prospects of a vaccine at all. So again, let's go back to it. It's a single-stranded RNA virus, a member of the coronavirus family. And how deadly is it? Well, you know, it's on the order in most similar to what virus? And I'm going to go to that for a second. Is it as deadly as HIV or smallpox or Ebola? The answer to that, of course, is no. What's it most similar to is the flu vaccine, the flu virus. So that's our best, as we go forward, I think that's a good place to start. This virus is very, very similar to the flu virus, and it does appear to be more contagious. The case fatality rates are very similar, and as we go through today, you'll hear some numbers that show some differences in different populations, and you'll hear about that. So as we said, knowing that we have a single-stranded RNA, airborne RNA virus, what does that mean for us as people that are treating these patients? It means that we have, early on in the disease, a very flu-like illness. So I'm gonna try to break it down into two parts, the early and the late disease. The early disease is very much like the flu. So you have upper respiratory symptoms, fever, headache. In this instance, it's kind of unique in that you lose sense of taste and smell in a lot of patients. But in general, it's a flu-like illness. And we can prevent that. We have prophylaxis, and we also have the ability to treat the disease early with a number of different medicines, including, and I won't name them all, but hydroxychloroquine, ivermectin, doxycycline, azithromycin, budesonide. There's a lot of strategies, colchicine. There's a lot of strategies we can employ rather than telling you to go home and do nothing. Doing nothing is completely against the Hippocratic Oath. Doing nothing is harm in this case. All right, and that's why we're here. So as we go forward and talk about the disease in the part two, we're dealing with a disease that is creating a massive amount of inflammation. And there's chemicals, IL-6, IL-10, tumor necrosis factor. These chemicals come out and they basically create a lot of inflammation in the body. And they turn the lungs to kind of mush. And early on in the disease, when you saw the x-rays, it looked like ARDS, which we thought the lungs were stiff. And so you know that a lot of those patients unfortunately perished because we didn't understand the actual mechanisms of what was happening. And so we're putting on ventilators and actually probably hurt a lot of patients. A lot of well-intentioned doctors hurt them without knowing because we didn't understand the pathophysiology in the late disease as well as we do now. So we're getting better results in the late disease. So we have massive inflammation, and then we also have massive thrombotic events. It's basically blood clots. So stage 1, you're basically like an upper respiratory flu-like syndrome. Stage 2, lots of inflammation, lots of blood clots. And it's really unique in the sense that if we look at the studies and we look at the pattern of how patients are doing, we see early on, like this is like immunology 101 for docs. When you check a white blood cell count, we see lots of lymphocytes. We know that's a virus. What's interesting about this virus is at the late stages, we get lymphopenia, very few lymphocytes. And interestingly, we get this massive amount of neutrophils, which we typically see in like bacteria and funguses. So many of the patients are being treated as if they might have a secondary infection. But these neutrophils are so massive enough that basically the ICU people I talked to said it's the stickiest blood they've ever seen. And they're called neutrophil extracellular traps. And basically what they're doing for these patients in the ICUs is treating them with anti-inflammatories, dexamethasone, solumedrol. They're treating with antithrombotics like aspirin and heparin, dipyridamol, Eliquis, Xarelto. There's a number of drugs. My point being that we treat the disease 1 differently than we treat disease 2. So there are 2 different stages. And in some sense, some of the things that we can use in stage 1, we may end up using in stage 2. But you have to treat the massive amount of neutrophils, the blood clots, and that's part of, you may hear some of that later this afternoon when we talk. So I think that's the major things that I wanted to talk about. It's a single-stranded RNA virus. It's an airborne RNA virus. It behaves most similarly to the flu, although we have this massive inflammation in the second stage of the disease. And I think as we go through the day, again, I don't want to keep beating the same thing up, but masks, social distancing, waiting for a vaccine, that's not a strategy. I'm sorry, that is not a strategy. I will not see a patient in my office and tell them to isolate at home if I have things that make a lot of sense. as Dr. Gold said, we have lots of evidence from older coronaviruses, and then it's been redone for this virus. So we have this particular virus, all the things that we did in the last virus to test for its effects in tissue culture with hydroxychloroquine, ivermectin, some of these other things have been done, and they were successful. And then we put them into practice in our practices as we see patients and we give them the medicines. And guess what? They worked. So with that being said, the other things I'll bring up are the data set as we go forward. Early on in the disease, it's very hard for us to have a handle on how many patients. We have a lack of awareness of the disease, and the data is unreliable. So now we've got this, and I want to address this PCR test, and this is the last thing I want to talk about. What does a PCR test tell us? Is it a live virus, a dead virus, or a particle of a virus? Does anybody know what that does? It's all of the above. So you can be a month out coughing up PCR, dead viral particles, because you were sick a month ago, and you still be coughing that up. What you're coughing up is a vaccine. You're coughing up a dead virus, okay? So everybody looking at this, like, we know, oh, if you're PCR positive, oh, you still are carrying around live virus. That's wrong. I'm sorry, but that's just wrong. And so the PCR is helpful, but it's just one more tool for us. The best help you can have is your clinical doctor examining you, your symptomatology, and your response to treatment. That still works. Okay, we don't need artificial intelligence for that. We're, in a sense, frontline doctors can diagnose you and can treat you, and they can basically do better than anything you can do on a test. The test is just a part of the picture, and it's often wrong. So with that being said, we're excited to be here because we want to get out, we want to get the word out, we want everyone to know we can do something about this virus, and waiting for a vaccine is not good strategy. We've got treatment. We've got lots of docs who want to put this into action. We need the government to get out of our way and let us do our job, and that's the number one thing we need, is let docs be docs.